About rheumatoid arthritis treatments, and I think as we get toward the end of the session, it's going to be a very nice lecture to take us toward that way. Peter, welcome back.
Thanks a lot, Artie. George was nice enough to insist that I give this talk, and I have to tell you, I'm giving this talk because basically I can't read. So when I pulled out the invitation letter last week, I didn't notice it was the one from a previous meeting. And it asked me to give 2 talks, so I made a second talk. When I got here, I found that George was giving my talk. So he was very nice and said, no, you're a guest. I'm disappointed because I like George's talks, and I like to see all those pictures, and I kind of feel, remiss that I'll be going home from Maui without having seen any skin. And it's just you can't have been in Maui. But George has promised that next year he will give the keynote opening address, and he has some particularly disgusting pictures to show you, some before and after stuff, so please come. So what I'm going to try to do, and I'm going to pick up on a lot of threads that were brought up during this meeting, and I'm going to give you a very opinionated talk on rheumatoid arthritis, achievements, gaps, and opportunities. What do we really need to do? Can we get there? Where are we going? And I always like to start with this slide, which is, of course, Auguste Renoir. Some of the older people in the room may actually remember his work. It's not as popular as it once was. But Renoir was an enormously influential Impressionist painter and also had severe rheumatoid arthritis to the point where, in order to paint, he had to have his assistants strap the brushes onto his wrists because his hands didn't work at all. And I'd like to show you that just because it reminds us of where we've come from. I mean, the older people in the room with a higher density of gray hair or absence of any hair will remember that when they went to clinic, many of the rheumatoid arthritis patients looked like that. And I doubt anybody has seen a patient like that in the last 10 years. So here's rheumatoid arthritis. I mean, we all know this. We know a lot more than we used to know. We know what's involved. I mean, we now have, by Robert Plinge's paper that just came out in Nature last month, there are 98 genes involved in lupus, in RA, and it's interesting that many of the genetic abnormalities in RA actually appear to be triggering pathways that are actually targeted by our drugs. So there are kind of a convergence of research and empirical information suggesting that we're sort of on the right path. And then we heard the mention of epigenetics, basically the entire set of mechanisms that controls the availability of genes. And we know that there are a lot of epigenetic mechanisms involved in RA, which probably accounts for the low concordance in identical twins. We're learning more and more about environmental triggers. I mean, we know about cigarette smoking, especially in Northern Europe, where they seem to smoke like chimneys and get RA, and probably less so in the United States, so we learned a little bit about that. We had mention of the microbiome. The microbiome is actually the organisms that live in your GI tract. People casually say that they're in you, but actually they're outside of you. Remember that your GI tract is a surface, and they're living in that surface. The reason that this is exciting now is because we didn't know about these organisms because nobody's been able to culture them. Only by molecular techniques could you find the bulk of these organisms, and we know from animal studies that the nature of these organisms controls or influences the nature of your immune system. So it can bias mice toward being a Th17-like mouse and being a pro-inflammatory mouse. It can bias it toward or away from having a lot of Treg influence. It can influence the sex prevalence of disease. Many diseases that we are involved in don't occur in animals in the absence of the microbiome. But the one thing that I have to point out, which was said earlier, is that the microbiome and probiotics have nothing to do with each other. The microbiome is largely anaerobic organisms. It lives there. You get it mostly from your mother, but you can get it after antibiotics. It can change periodically. Probiotics are largely aerobic organisms that don't survive in your GI tract. So those are really two different concepts. And finally, we know a lot about P. gingivalis. Periodontal disease. All of these things conspire to give you inflammation in RA. All right, so let me start off with where I think we're going in RA, and then I'll kind of amplify a little bit. I mean, I think a goal, which is going to happen in the next 5 years, is that we will understand the full array of genetic polymorphisms that contribute to RA, and we'll begin to understand their impact on cellular function. We'll understand why some people are more prone to get RA and others aren't. We'll understand the impact of epigenetic modifications and also their impact on function, and I think within 5 years we'll be able to identify individuals who are at increased risk for RA quite easily. We'll understand the impact of the microbiome and RA pathogenesis. I think that work is going on now, and we'll begin to think about how we can change the microbiome in order to protect or to prevent RA. I think we'll know much more about environmental triggers. There's a lot of work in this area in terms of environmental pollutants, in terms of various antigens, microorganisms, what have you. Despite what Jack said, we will have effective biomarkers that will predict prognosis and response to therapy. I think there is a vague possibility in the next decade that we might actually learn what causes RA. That would be nice. And I think that we'll understand to some degree the extent of specific processes that are operative in individual RA patients. In other words, we'll actually be able to do personalized medicine, and we'll use all of this information to develop what we don't have at the moment, which are curative therapies. We have suppressive therapies. We're pretty good at using them, but we don't have anything that has any possibility of curing. Let me just emphasize personalized medicine, because I think this is an important concept, and it's something that rheumatology should embrace. And it's obviously something which nobody quite understands, because there are many, many definitions out there. There's a personalized medicine coalition. I don't actually know if they're associated with ASAS or with one of these other groups, but there's some group of people who get together in a hotel room somewhere and talk about this stuff. But the use of new methods of molecular analysis to better manage a patient's disease or disposition to disease, we do that. We could say that rheumatology does that, providing the right treatment to the right patient at the right dose at the right time. This is a typical European statement. Let's offend nobody. Let's make everybody feel good, and then we'll get the Lithuanians to vote for this. So we also do that. We could actually claim that we do personalized medicine. But then Obama got involved, and this is the tailoring of medical treatment to the individual characteristics of each patient. Well, that sounds a little bit more scientific, but we still do that. And then, of course, we have the AMA. They couldn't miss this one. Healthcare that is informed by each person's unique clinical, genetic, and environmental information. We pretty much do that. Then, of course, the NIH had to have an opinion. And the NIH opinion is always quite interesting and, unfortunately, usually rules the day. A form of medicine that uses information about a person's genes, proteins, and environment to prevent, diagnose, and treat disease. In no way does that say to make the patients better. It's to treat disease. So it's interesting to read all this, but I think rheumatology needs to embrace this, because this is what basically we do. This defines us, and it makes us different than primary care providers, and it makes us different than what insurance companies want us to do, which is those who follow algorithms usually decided by somebody else. All right, this is Jack's slide of rheumatoid arthritis. These are the stages of rheumatoid arthritis. And if you remember, when I was a faculty member, I remember that the one thing the rheumatologist could do that nobody else could do is actually name all these deformities. So you'd always walk around and say, aha, swan neck deformity, and stuff like that. It's a boutonniere, must be RA. So anyway, we don't see this anymore. Basically, this is RA in 2014. And I think that this is something that we should actually all feel very good about. But of course we don't. We complain about it. I mean, this field has anhedonia. We just can't take pleasure in the stuff that we've actually done. Over the last number of years, there's better health status for our patients. There's less work disability, as we heard, less sick leave, as Glenn told us, and there's certainly less surgery. So I travel around and I borrow everybody's slides. Here's one from Torek Fien, and this just documents it in their clinic in Oslo over a period of 15 years or so. You can see that basically every parameter that you look at is better in terms of patient-reported outcomes, in terms of function, in terms of pain, in terms of fatigue, in terms of patient global. Essentially, by whatever it is we've done over the last 15 years, we've achieved an ACR 20 in our patients. We actually should probably apply for that, for some sort of anyway. Here's what happens now, also in Oslo, but I think it's all the same. This is the response to, in this case, just methotrexate in a general clinic, taking care of rheumatoid arthritis patients. And you can see in 2000, the response was ACR EULAR response was here, and you can see over the years, patients are doing better, and this is just in response to methotrexate. The DAS remission rates are going up just in response to methotrexate. Patients are doing better. So there's no question, I think, and the data we heard from all the registries show it, the data that we've heard over this conference show it, patients are doing better. And a number of things have happened contemporaneously with patients doing better. Rheumatologists have embraced early aggressive therapy with effective DMARDs. I mean, prior to 1980, there really wasn't much of an effective DMARD available, and certainly our tendency was to watch, do no harm, and after 15 years, think about perhaps starting gold. We don't do that anymore, obviously. I'll talk about this a little bit. There's the idea that we're finally sort of moving toward what one might call quantitative rheumatology. We routinely measure things, and that's gotten all conflated with this treat-to-target concept, which I'll mention a little bit. We've also had the introduction of biologics, and Shireen would tell us that the epidemiology of RA is also changing, in that it's somewhat less frequent and seems to be somewhat less aggressive. So all of these things happened at the same time as people got better, and it's actually quite hard for us to dissect which, if any one of these, was the most important, and it's probably the combination of all of them. So here's just to show you that early aggressive treatment really is what's happening again in Oslo. I must have just borrowed Tora's entire flash drive. But anyway, the most important thing, here's a duration of disease before starting methotrexate in 2000 in Oslo, 10 months. Here's the duration of disease before starting methotrexate in 2009, basically 10 days. And that's probably very similar to what's going on in all of your practices. Early aggressive treatment is now basically standard and has been standard for the last decade or so, uniformly throughout rheumatology. But you can also see the patients are actually, when they're starting methotrexate, they actually have less active disease than they used to. So by all parameters, we're aggressive, we're much earlier on, we treat them very quickly before they get into very much trouble. The other concept that this is based on, and I've just borrowed a couple of slides here to show it. I mean, this originally was shown in Finland, and then in Scotland, and then everywhere else. And of course, the group in Leiden is very good at showing what somebody else has shown and doing it better. And here you can see basically if you start treatment before 12 weeks or after 12 weeks, that basically the number that go into remission is much greater if you start within the first 12 weeks, and sharp scores level off much better and don't continue to progress. And this, of course, is developed into the concept of this so-called window of opportunity, that there's a time in these patients when you can treat them and that you have a lasting effect on the disease. This is Joseph Smolin's group, I think, from 2004, and they coined phrases. This is very early rheumatoid arthritis, again, less than 12 weeks. And here's late early. Probably sounds better in German. But anyway, this is late early. These are individuals who have rheumatoid arthritis for less than a year, but more than 12 weeks. And you can see that the DAS28, you get into low disease activity if you start earlier than you do if you start later. And I have to emphasize, this is not using big gun therapy. This is basically using the chemical DMARDs that were popular in Europe. And at that time, for example, in this clinic, I think less than 20% of the patients were getting methotrexate. So this is on sulfasalazine and other drugs which we wouldn't necessarily consider to be high-intensity DMARDs. But the point is that early treatment is better than late treatment. So that's, and again, this is the same thing with X-ray here, Larson scores, which we don't use anymore. You treat early, X-rays do better and stay better, whereas if you treat even a little bit later, in this case, just a year of disease. And I think everybody now has embraced this, and the treatment, we have this concept of the window of opportunity. But there are a lot of research questions around this. There are a lot of things unanswered about the window of opportunity, and we don't know if it's a real window or perhaps not quite so real. So this is from Magritte. What we don't really know is how long does it last. We don't know that. We don't know if it closes, why. What happens biologically after 3 months that's different? If we actually treated with biologics rather than with sulfasalazine, is the window longer? Does it stay open for a much longer period of time? We don't know that. We don't know anything about the biologic, genetic, genomic characteristics of this so-called window. We don't have any biomarkers to identify when patients are in it or moving out of it, and we certainly can't identify it in an individual patient. So I think all of these things would help us to know which patients need aggressive early therapy, or we can just treat them all early aggressively, as I've heard said over and over again, without actually knowing what we're doing. So then the question comes, can we identify aggressive disease before it becomes aggressive? And I think that becomes a sort of very important question, because we are trying to prevent long-term disability in these individuals, as well as trying to treat their symptoms and their pain. And it is sometimes hard to convince a patient that you're trying to treat long-term disability when they're really there because they hurt. Well, there's a lot of information here we know about that. If you take people with early arthritis, and many people have done this kind of thing, and I think it's generally accepted to be true. I mean, if you just take individuals who have no serology and no area of inflammation particularly, being a woman gives you a greater likelihood of having aggressive disease at 10 years than being a man. If you have an anti-CCP, that goes up in both groups. If you add a rheumatoid factor, that goes up in all the groups. If you add rheumatoid factor rather than ESR, it goes up the same as rheumatoid factor. And if you add them both, then you can get in some cohorts to a very high likelihood. And this has, I think, become a kind of a practice principle that you look at these things, and if you see a female who's CCP positive, who has an elevated CRP or SED rate, and perhaps is rheumatoid factor positive, regardless of how she looks to you, and regardless of whether or not you do an echocardiogram, she gets started on treatment. Sonography, she gets started right away. It's the same kind of data from the French. It's quite colorful. It is French. It's actually almost impossible to interpret what they're saying, but basically, it's French, but fundamentally what it's telling you is that if you're looking for people who have erosions in their cohort of early individuals, it's individuals who have a lot of swollen joints, CRP elevated to a certain degree, not a high degree, but an elevated CRP, and those are the individuals. So we know that kind of thing. Jack Cush kept trying to say that to me 15 years ago, but at least we know that this is true. So there are things that we can do that predict outcome, but there's certainly, and here's information also from Oslo, where now you're looking at individuals who have arthritis of less than 16 weeks, but it's a kind of undifferentiated arthritis. And the question is, what can you do in that stage to predict what will happen to these individuals? And basically, again, if you look to see whether or not they're CCP positive, they have a much greater likelihood of moving on to RA and even a greater likelihood of requiring DMARDs or having persistent synovitis. If their small joints are involved rather than large joints, and if they have a rheumatoid factor, they certainly are more likely to move on to RA. So we know that these are things that can tell you that there's aggressive disease, but they're still pretty crude. I mean, we really do need much better biomarkers in individuals, especially those before they get full-fledged RA, to be able to predict aggressive disease, because those are really the individuals we're trying to identify and to treat, and we certainly need more precise biomarkers. And there's a lot of activity in this field that would allow us to do this, and it's likely it's not going to be a single test, but rather a combination of biomarkers that involve genetic information as well as functional information and perhaps environmental exposure. Okay, so the second thing that's happened is there's this concept of tight control. And this has become a quite confusing area, but an area that's been embraced by many, and there's a website that you can go to, Treat to Target website, and everybody uses that in their presentations and talks. But it's actually pretty hard to figure out what they are talking about, because this tight control, treat to target, involves a lot of different concepts. To try to summarize the principles and to show you some data, what does this actually mean? And again, this was developed initially in Scotland and Finland and then adopted. And basically, the first concept is to identify a treatment target. So the treatment target could be remission, it could be low disease activity state. Those are usually things that are selected. And usually that involves discussing with the patient what they're looking to achieve. And different patients have different ideas when they find out what might be involved. So the first thing is to identify the target. The second thing is to monitor routinely using standard quantifiable outcome measures. And that usually involves routine visits. In Europe, it's 1 to 3 months. That's usually not possible in the United States. And using a standard measure and adjusting therapy according to whether or not you've reached the target. So that's the second real principle here: standard measures, frequent measurement, and adjusting therapy according to the target. The third one is to continue to monitor routinely, again, looking to see if you've achieved the target, and then to adjust therapy. And the hard part, which is, I think, the part that's the most controversial, is that the adjustment of therapy in real treating to target involves adjusting the therapy according to the protocol. In other words, a group, usually the investigators or the physicians in a clinic, have discussed what the protocol is, and then you follow the protocol. You don't necessarily treat according to the seat of your pants, but rather you follow the protocol. So that's protocolized medicine, which I must say is something I find quite astonishing that rheumatologists have embraced, but nonetheless. And then you continue to do this as long as the target is not achieved. Once the goal is achieved, you continue to monitor the patient a little less frequently, and you adopt therapy if the target state is lost. Now, this concept has actually been looked at. There's a lot of papers on this, and there's a recent paper that actually looked, and this is again a group of physicians in the Netherlands who actually believe in this. This is like going to Catholic Church and asking, do they really believe in God? They actually have gotten together, this group, they've agreed to a protocol, and then the question is, at the end of the study, do they follow the protocol? And the answer is about 2/3 of the time. So there's no question that it's very difficult to do this protocolized medicine, even in a population of physicians that are agreed beforehand to do it and have agreed to what the protocol is. Does this stuff work? Well, there's a number of papers. There's been a meta-analysis. There's a number of papers that in looking at early arthritis, in other words, basically the initiation of therapy, that this kind of approach is more effective than doctors treating it by themselves or with their own decision-making. And the most effective is when you combine systemic monitoring and protocolized treatment adjustments, and you can take a look at that paper. And the impact is actually quite high. There's only one paper that looks at this in established disease. I don't know if you can see that, but that's a paper from Canada with an adalimumab trial in which they got together. They're Canadian. They couldn't agree too much on the protocol, so it was kind of not exactly protocolized, but it was an attempt to protocolize to a certain degree, at least to influence the treatment. And what you can see is if you were normalizing, or the goal was remission or no swollen joints, what you can see is that achievement of low disease activity state actually occurred faster in those who were doing this kind of treat-to-target kind of approach than in those in the same clinic who were not doing that. And you can see the same true as remission. But by 6 months or a year, there was no difference whatsoever. The only real value, apparently, the persistent value of doing this was that the retention of patients was much greater if you were doing a kind of a treat-to-target approach. So the patients seemed to like it enough that they came back, and they continued to come back even though the effect of this approach was gone within a certain period of time. So whether or not this is going to be actually effective in established RA is not certain at this point, but it certainly does appear to be effective when one starts with very early disease and starts with this kind of approach. Okay, let's move on to biologics. I have a lot of talk about biologics here. Here's biologics that are available. I think there are 9 biologics available, and 2 come in 2 different forms, so 11 different possibilities, all approved for rheumatoid arthritis. And let me make some comments about biologics and talk about what I think we need. There are 11 available agents, 9 individual products, and 2 come in 2 different forms. We saw a couple today, but there are very few head-to-head trials, so it's hard for us to know exactly which one would be better, and we certainly don't have any information as to which one would be better in specific situations. There are no biomarkers to predict or to monitor outcome other than standard disease measures. So we actually don't have a way to say an IL-6 blocker did X and Y, therefore we can expect A and B. They are associated with serious side effects, but as Roy pointed out, rheumatologists become quite adept at dealing with the side effects, and these don't seem to be a barrier to therapy anymore. The order of them is really not established by science. It's established by historical precedent, regulatory guidance, and reimbursement. There's no real reason as to why scientific reason why one would routinely start with an anti-TNF rather than try to find those who might respond to a T-cell directed or a B-cell directed therapy. All of that's just has to do with how the trials were done, how the regulators see it, and how the reimbursement is carried out. The question has come up, and we had some discussion. This is sort of a new challenge to biologics as to whether or not they're actually better than combination DMARDs. I'll show you my version of that. And also, one thing that's quite interesting is whether or not there's a role for these things in mild disease or in disease that doesn't appear to be associated with erosions, effusions, what have you. And of course, the driving consideration here is that these are very expensive, and that's always involved in the decision making. Okay, so here is the famous studies that have shown conventional therapy is as good as DMARD therapy. And this is Ron von Vollenhoven's paper that was in Lancet, and this is a comparative effectiveness study. This is not an RCT. This is in a clinic, docs are treating, and basically the idea here is that if you look after 6 months, that triple therapy is comparable to, biologic therapy is better than triple therapy, and but if you wait out 36 months, they're both comparable. The X-ray findings clearly are different, but we heard 2 days ago that who cares about a sharp score of 3? Well, a couple of things to point out on this study, and that is that the ACR responses are 25% here from either of these therapies. I mean, I'm not sure what's going on in Sweden, but nothing seems to work very well. And the second thing is, I mean, if you have a patient in your office in the United States and you say to her or him, I have 2 therapies, and one of them will make you feel better fast, and the other will make you feel better in 2 years, which would you like to have? That patient is telling me I'm going to visit Alvin Wells because he's giving me the good stuff. I know that. So, I mean, to me, 2 years of active disease is not a trivial matter in a patient with rheumatoid arthritis, and actually, we don't have information about whether or not this difference in radiographic progression translates into a long-term issue about disability. This is the TIER study, same kind of thing. You know, the biologics work better initially, and then after a while they all work the same. But again, you have the issue as to whether or not 2 years of active disease is something you should tell your patients about. This is the same study, and this is the non-study that was published in the in the New England Journal of Medicine. This is the Odell business, a study which basically was powered on 450 patients and in which they enrolled substantially less, a study which had a primary outcome which didn't fit the data, so they had another primary outcome. And then let's look at the data. What they did, this is actually pretty clever what they did. They made the primary endpoint 48 weeks, but there's a mandated switch of medicine here at 24 weeks if you don't meet certain criteria. And what you can see is the red is Enbrel, and this is triple therapy. So initial therapy, Enbrel works better. It maintains better. If you're not a responder to those, if you flip to Enbrel, you respond better. And if you flip to triple therapy, you don't respond as well. And if you look at those, and actually the statistics here show Enbrel is better. If you look at the end, you're lumping all of these people together and you're saying they're the same. But again, the issue is, are you going to sit there and tell a patient that, don't worry, by 48 weeks, by 2 years, you're going to be doing fine? That's what we used to tell patients when we treated them with gold. But then we knew. We started them as a fellow, and we knew for sure we would be done with our fellowship before that period of time was gone, and it was somebody else's problem. Okay, biologic therapies. Are biologics more effective than combination chemical DMARDs? I believe the data we already have has addressed that question. Does the minor difference in radiographic impact translate into a long-term clinical difference, especially with regard to disability? We don't know that, and I don't think we should diminish or discount radiographic changes until we know whether or not they translate into long-term disability. Are there individual patients who absolutely require biologics? We don't actually know that. We're doing it based upon some crude biomarkers. We need better biomarkers. Is there a predictable difference between the biologics? We don't actually know that, but we need to know that if we're going to do personalized medicine. Can we identify individual patients who require specific biomarkers? Well, there's a very interesting study from Genentech that just came out in ARNT that looked and is beginning to develop some gene expression profiles that suggest perhaps we could tell individuals who have a lymphocyte-driven disease or a macrophage-driven disease, and there is some initial data suggesting that there might be different responses to different biologics. We need to do more of that kind of thing. Can we predict clinical responses to biologics? No, because we don't have the biomarker. And the big $64 question, which we've all embraced, is what if this low disease state is great, but it's not no disease state, and we actually don't know anything about the biology of low disease state, and we need to learn that, especially before we become comfortable with this idea. Okay, let me finish off with a cartoon. This is again from our buddies in Holland, and this is describes the European initiative. And this, what they're trying to do is to make the point that rheumatoid arthritis is a continuum that starts from genetic risk and then moves through a pathway, and that if we were smart enough, we could actually identify these people and we could do something much earlier, which is a laudable idea. So it suggests that there are people who have risk factors for RA, and then some of them are exposed to environmental challenges like smoking, and then some of them make autoantibodies, and then some of those get arthritis, and then some of them move on to undifferentiated arthritis, and then they have RA. And it's a very interesting cartoon, a very nice discussion, but what I've added here is actually the risk of RA, to try to understand where we could actually intervene. And it's pretty clear that the likelihood of a person not having at least one genetic risk factor for RA is about 10 to the minus 13th. So there's no human being that doesn't have one risk factor. What that converts to is that having genetic risk factors basically gives you a 0% chance of RA, because there are so many more who have them than will get RA. So that's not really going to be helpful. Environmental factors, again, the risk for RA in smokers is really pretty small compared to non-smokers because there are so many smokers who don't get RA. So this is interesting, but I think the first period of time that we could even think about an intervention would be in individuals who've actually had the risk factor, had the environmental stimulus, and begun to make autoantibodies. You can look in the literature, though, and see what the risk of these individuals getting RA is, and that's basically 1.5% if you're rheumatoid factor positive, and 5% if you're ACPA or CCP positive. So it's still a very small risk in these individuals, and perhaps the risk isn't high enough to think about an intervention. Of those individuals who get an arthritis even an arthralgia that we can't diagnose but has antibodies, here the risk is beginning to get higher. And we can see that it ranges anywhere from 18 to 35%. That's a situation where you could begin to think about an intervention. If you get undifferentiated arthritis, a kind of persistent arthritis which still doesn't meet criteria, depending upon the nature of that arthritis, again, the Dutch have given us a nice scale that basically says if you have no features of RA, you got 16% chance of moving to this, and if you have a lot of features of RA but don't quite make criteria, you can be as high as 85%. And this is another time when we could think about intervening and actually preventing the development of arthritis, because I think in the long run, it's really beginning to target right in here that we're going to have the the chance of actually having an intervention and preventing RA, which in the long run may be easier than curing established RA. So the research agenda of pre-RA, when does rheumatoid inflammation really begin? Probably sometime after you make antibodies, but way before you get arthritis. Which genetic factors are associated with the development of autoimmunity in these individuals? And they're probably different than the genes that are associated with arthritis. If we could identify them, and they've been identified in lupus, we probably could identify them in RA, then perhaps we would have stronger indication of the individuals who need to receive preventive therapy. Are there genetic, functional, regulatory factors that limit the full development of arthritis? For example, the bulk of people make autoantibodies don't get arthritis. Many of them probably have regulatory features that we could, if we understood them, actually exploit therapeutically. Can predictive models be developed that account for manifestations in individual patients, and can they be used to predict prognosis, progression? I hope so. Are pathogenic mechanisms in autoantibody positive and negative subjects different? We don't know that at all. And can treatment of individual patient subjects prevent the progression for RA? And I think that's the big question, and I think in another meeting in 5 years, we'll probably be talking about that in a lot of detail. So anyway, let me finish, because 50 years after Auguste Renoir got rheumatoid arthritis, Raoul Dufy got rheumatoid arthritis in 1950. Here you see him sitting in France, and here's a poster of him, and you know that his paintings are extremely famous. He's basically defined the way we think about France. But he got RA, but he was luckier and unluckier, because by that time there were clinical trials going on in cortisone in Boston. So he went to Boston, and he got on a clinical trial of cortisone, and his disease went completely away. He was so excited, and in fact, he painted this famous picture called La Cortisone, which is actually his experience of cortisone, and you can see it's quite vibrant a little bit. He was a little loose at that time, and so it tells you that there was progress. Of course, the problem with him was that nonsteroidals were developed pretty much around the same time, and the combination of nonsteroidals and La Cortisone caused him to die of a massive GI bleed. That doesn't happen anymore with our patients, and I think that it's just interesting to see the issues that we've gone through, and that what we've overcome and what our patients have overcome, and that now I think we can honestly have a discussion about cure of established disease or prevention of those at risk for rheumatoid arthritis. So thank you very much.
Awesome. Thank you very much, Peter. We have questions and comments and discussion. Front left microphone.
So we get a lot of patients referred to us strictly for abnormal blood tests that may or may not have been ordered for appropriate reasons. Maybe a patient's fatigued and the primary care doctor gets a rheumatoid factor and it's positive. My question is, at what point, how often do you follow these patients? At what point do you treat them, and what makes you say to them, what do you tell them, and at what point do you say, you know what, I think it's time we need to initiate treatment?
An isolated rheumatoid factor in an individual gives you a likelihood of about 1.5% of going on to having rheumatoid arthritis. It's not zero, but it's very low. An isolated ACT bar gives you about a 5% chance of going on and have arthritis. It's higher if you're a woman, it's higher if you have a family member with rheumatoid arthritis, but with what we know at the moment, in those individuals, it's not worth treating. If, however, they come in and they have nonspecific arthralgia or arthritis that doesn't meet criteria, then the likelihood that that's going to go on to chronic persistent synovitis becomes much higher, and I think that's when you can begin to treat or think about treating. But it's all a numbers game at this point. But the probabilities are in the literature, and it's on that slide I think I showed you.
Are you following these patients, or are you simply telling them, come back when you develop pain?
The Dutch have been following them. There's lots of huge cohorts of these people who have been followed in Europe where it's possible. And they've been able to see that. You know, in a practice in the U.S., it's very difficult to do that.
Front right, Jack?
So I agree. It probably doesn't matter what you do with anyone as long as you do something. And metrics, I think, are helpful in improving that what you did was beneficial. I think what I'm stuck with, though, is I still don't know what to do, and I don't like the scenario that's going to play out on the patient who's going to respond or seems to respond to nothing. You know, these people, we all have tons of these people who have been around the block. They have failed multiple oral DMARDs. They've been on other biologic DMARDs, and it seems to be a real crapshoot. They are the minority, but they tend to be in our offices. And should we be worried about those people? Or should that be the focus of our better understanding of disease, or are those going to be, is that the scrap pile of investigation that probably will never get dealt with?
No, I think it's going to get dealt with because it's a growing problem. In other words, there are 11 ways to treat people plus the oral DMARDs. There's a lot of therapy, but there are still individuals who progress through it. Now, some of them have been undertreated, some of them haven't had enough time to respond, but that's a group of individuals who one might argue has a higher genetic load or a different epigenetic possibility or the wrong microbiome, but that's a group of individuals that I think needs to be studied. And you know as well as I do that all of the trials have shown that a second biologic is always less effective than when it's used the first time. So over and over again, we're hearing that there is a subgroup of people, and the question is, what's their nature and what should be done about them? And I think we're getting into the situation where we have the tools to address that.
Front left?
Yeah, just a question. Is there a clear relationship between radiological progression and disability in patients with rheumatoid arthritis? Like, should we manage patients with rheumatoid arthritis only on clinical response? Like, should we ignore the radiological progressions and erosions that develop even patients who are in remission?
Well, I mean, there's a lot of older data that's tried to look at the components of disability. And clearly in those with established disease, radiographic abnormalities contribute about half of the disability. In earlier patients, it's more swelling and inflammation, but there's certainly a major component of long-term disability that's completely predicted by the radiographic involvement. The difficulty is that the companies don't want to do long-term disability studies because it may be a five-year study. So should you worry about radiographic progression? I think yes. We don't actually know how much radiographic progression is worrisome, but you know, if you have a change of 3 sharp units a year, by 10 years you've had a pretty a substantial change, but we don't actually know whether that's going to translate into disability, but we'd be worried about it. So I think it's very important to consider radiographic progression, yes.
Back left, Marty?
Peter, thank you. Jack asked one side of the spectrum, which is the patient who nothing is working, they're horrible, they're falling apart. What about the other side of the spectrum? How hard should we be treating these patients? Should we push everybody to remission, no joints, no tender, no swollen? Or is there a gray area where you can say, you know, they're doing pretty well and that's going to be good enough?
You know, when I first started rheumatology, everything we did was do a little bit, that's good enough. Nowadays, you know, I think patients won't tolerate that. Most patients want to live normal lives. You see the ads, the direct-to-consumer that you watch all the time, I know, and the individuals that are on the ads for Humira and for tofacitinib are normal people playing soccer with their kids, and I think that's the view. So, I mean, I think it's something that one has to have a conversation with the patient, and if the patient really wants you to go for no disease, I think that you have enough options that you can try that. If the patient says, you know, I'm 68 and I don't care about playing golf, and as long as I can hold my cards or pull the lever of the slot machine, I'm a happy camper, then you obviously have a different mandate. And that's why I said on the treat to target slide that the first thing is with the patient to define what the goal is. And I think we have lots of different kinds of goals now, and that's totally different than what we used to have. Roy, I was waiting.
Well, I wanted to end. So 2 quick comments. One, Marty, that's an interesting comment because Peter and I actually started about the same time when gold was the gold standard and a little bit was really great. And now what I'm seeing is the people who are older rheumatologists, we want remission. With the patient, we want remission, real remission. And not, oh, you're better, it's okay. But it's interesting that we've come this way. You talked about biologic markers. What do you think about the utility of the Vectra in this instance? Does it help? Doesn't it help?
I think what we need are actually biologic markers, probably specific ones for each drug that are going to tell you whether you hit the target and whether you hit it hard and whether or not there are outcomes in the disease that we know are important. So I think it's a beginning, but I think what we're going to see eventually is a lot of the data that the companies have been collecting from their clinical trials, their microarray data, their gene expression data, coupled with some genetic outcome markers is going to probably be more helpful, especially in terms of defining patients who might respond one way or the other and who then are responding. And I think from that, we'll build on other ones. So yes, I think it's a beginning, but I think we're going to wind up with markers that are highly specific for each agent because they're hitting completely separate pathways.
Well, thank you very much. Okay, well, we're running a little behind. There's still one session. That was the last didactic session, but we have an interactive session. So for those of you who are going to stay, we have lunch with the faculty. We'll put them up here and ask them